When we're looking at treatment, there's 3 phases of treatment, right? Like, in our clinic, we call it Men Move Maximize. The first phase is all about symptom reduction. We're going to get you out of pain. And as we're working on getting them out of pain, which is a lot of education, a lot of activity modification, because the spine acts like a credit card. So it's not the stuff in the moment that causes an issue. A lot of times people will be like, sometimes I'm doing nothing and I have a whole bunch of pain. And sometimes I do a lot and I don't have any pain. It's just like, how much have they spent throughout the day?
If you have been wondering what you're missing, where most clinicians go wrong, it's kind of taboo to ask for help in the PT world. So we're going to dig in, brutal honesty, where people go wrong and what they're missing. We're going to talk about the initial evaluation, clinical reasoning, and how to get from a patient walking in the door to figuring out what's actually going on. And as a clinician who has done a residency and 2 fellowships and now mentors clinicians internationally, where is it that most clinicians are struggling? Like, what's the first piece of the puzzle that they have yet to address that they need to?
Yeah, that's a great question. The first piece of the puzzle, I think, honestly, is like the ego that people have, because they're like, oh, I'm pretty good. Like, I don't know, most people get better. I do some things and people tend to get better. And asking for help is like kind of taboo in the PT world, right? So I think that's the first thing, is like checking the ego and like knowing that it's okay to not know everything. Like, I don't know everything. You don't know everything. Like, I'm constantly learning. Then it's like even knowing what the intent of your evaluation is, right? Like, most people would tell you like, well, I want to figure out what's wrong. But like, what does that even mean? Right? So like when we're looking at the intent of the evaluation, like the first thing that we need to do is like the intent is to determine whether, a problem is primarily in the anatomical joint or the associated soft tissues, right? Which includes neural structures. Even if it's foot pain or finger pain, like we need to be considering the neural structures, even if there's no like proximal pain or nothing clearly connecting them, right? And then we need to decide if joint hypomobility or hypermobility is present and relevant. We have to determine whether the treatment should be directed at that point towards pain control or biomechanical dysfunction. And then getting enough information to be able to use classification systems to identify the mechanical stressors of load, position sensitivity, neural tension sensitivity, and static position sensitivity, right? And that stuff also applies to the distal joints, right? And most patients honestly are like, their symptoms are affected by a combination of these mechanical stressors. And again, like most people try to go in there with like this idea of, I'm going to figure out like the pathoanatomical diagnosis. In like the pathology of the condition is important from like a medical perspective, right? But it doesn't really direct patient treatment and education. Like being able to classify these things and having this full understanding at the end of the evaluation is what helps direct the treatment and the education of the patient.
Yeah. So that's a lot to consider, right? So when you're talking to a clinician and you're giving them, this is the difference between what you're doing and what you need to do, how would you have them start and say, like, what does that evaluation look like? Or what do you walk into the initial evaluation looking for?
Yeah, well, I mean, it starts off with the subjective, right? Like you need to understand everything that's going on. You need to lead the subjective. Like patients come in, they try to be super fucking helpful, right? Which means they give you a whole bunch of information about absolutely nothing relevant most of the time. And then you're 30 minutes in because you don't know how to lead the subjective and interrupt tactfully and tactically to keep them on point, right? And you feel rude, and then you just start randomly testing. So like the first thing that, we have to nail down is the subjective. Like, first of all, like what are your expectations from today, right? Like we need to know what are the expectations, and we need to have, an organized thought process to be able to ask the questions that'll give you the most insightful information, right? Like we need to be making eye contact. You need to not be feeding the computer, like less typing, like written notes are better than the computer, so you can like build that rapport, right? So then we want to ask, hey, what presently, right now, like what is your main problem, right? And if they start hypothesizing and telling you like what, why for a cause, all this stuff, and they start going off the rabbit hole, you can just tell them, hey, just tell me like what's going on, and I'll try to make sense of it for you, right? So we want to take that responsibility of them trying to tell you why it's going on, and like you're going to tell them. right? And then find out how long it's been going on, right? Like how long has this episode been happening, right? Because, chronic will have more peaks and valleys and might take a little bit longer to, recover. If it's acute or if it's brand new, like they might recover pretty quickly. So we want to know also about like the onset, right? Like what is the mechanism of injury? If somebody has a lateral epicondylitis and there's actually no mechanism of injury, it should make you go, what else could be causing this? Like there's no increase in loading, nothing changed, just suddenly I have elbow pain, right? So like, how did this start? Like, when did you first notice it? Like, was it sudden? Was there an incident? Was there no incident? Was it quickly? Like, they turned their head and they had like acute locking, right? Did they wake up with it? Did it happen in the morning or in the evening? Did it start off gradually? Was there like a predisposing activity, like postural or repetitive stress over time? Or was there like a past incident that happened? And leading into that, we want to find out like, okay, have you had this or something like this before? What kind of caused those previous episodes if they had it, right? Like, and then we want to dig into, the location of like, where do you feel most of your symptoms, right? And if they're like, it's my schneck, cool. Does the center of the pain feel closer to the head or closer to the shoulder, right? Which can still be difficult because of referred pain. Then we want to find out, is there anything other than pain? Do they have weakness? Do they have numbness, tingling, right? How would they describe the pain? Is it sharp, dull, throbbing, burning, tearing, right? And most people get, most of those questions fairly on point, but it's not so organized. And then like we've got to dig in even deeper than that and look at this on a 24-hour clock. If you describe your symptoms on a 24-hour clock, like what time of day is the worst for you, right? Is it the morning, the middle of the day, the evening, or at night when you're trying to sleep, right? And then what's the best for you? And then clarify, right? If they're like, I wake up with it. It's like, okay, like, is it like when you're still laying down in bed or is it after you're upright? Like, have you opened your eyes and you haven't moved yet and you have pain? Or is it after you start moving? Because those are two very different situations that we got to go down. And then we got to find out about their aggravating factors, like what I call maps, right? Like what movements, activities, positions, and situations make them feel worse or bring on their symptoms, right? And it's like, hey, you already said sleeping, like help me add to that list. What are like the top 3 things throughout the day that you have, pain or difficulty with doing? And then prioritize the list, right? From like the worst to the least bad, and then find out the tolerance with each. And then after you have that list, then you can get into like relieving factors. Like, hey, what makes your pain less bad, right? Well, it hurts when I'm standing and when I'm sitting, right? Okay, well, would you rather be sitting or would you rather be standing, right? Would you rather be walking, laying down? Like, what would you prefer to be doing, right? And then we have to find out about their reactivity or their irritability. Like, how long does a flare-up last? Is it a few hours? Does it calm down that day? Is it like a couple minutes? Is it 3-4 days? And then obviously clear out any like red flags, episodes of extreme dizziness, fainting, blackouts, like if they have extreme apprehension of like moving their head, if it's something cervical, or they've got bilateral numbness in the hands or the feet, things like that. So like really getting a really solid view of the whole situation as you're going along.
Yeah, I think that's a really good point because most clinicians, I would say like especially fresh out of school, like I'm looking back at how it was when I first came out of school, you have just this checklist that you go down, you get the information based on like what you were taught to ask in the subjective, but then you're not looking for patterns necessarily. And then you have to actually internalize all of that information with clinical reasoning before you start your tests. Because I think most clinicians take that and then they're like, okay, so next I'm going to go through range of motion, and then I'm going to go into strength testing, and then I'm going to go into all these check marks of the evaluation. And it's like the clinical reasoning dictates the rest of it. So then once they have all of that information, what's next?
Yeah, I mean, it kind of depends on the body part and the pain behavior and the pattern. So like once they have all that information, like we need to get all of that information so we can start to pick up on the patterns, right? So if somebody has, I don't know, let's say shoulder pain and it doesn't hurt when they're using their arm, like that's a little weird, right? If somebody wakes up or they come in, they say, I think I tore my rotator cuff in my sleep, and they like grab their shoulder like this, it's like, okay, well, what are the chances of them actually tearing their rotator cuff in their sleep? So it's like they need to have a baseline understanding of the patterns of behavior for different types of pain, right? And they need to be able to very thoroughly clear out the spine based on the patterns, because there's a lot of things that get missed, honestly, that are just, it comes back to the spine, and people think that they're pretty good with the spine, but they don't understand the patterns. They don't understand how to use the neurological vital signs to actually uncover when it is coming from the spine or not. A lot of people are just like, oh, this kind of looks, maybe it's like it's a back. This sounds like maybe it's your back. Like, let's check that out. I'm not really sure. Okay, maybe we'll do a little bit of both, right? So like taking that information and being able to come up with, your list of differential diagnoses in your head, and then clear out the primary things, like the bigger things that might be underlying first. So if you're like, is this a neck or is this a shoulder? Is this an elbow thing or is this a neck? Is this plantar fasciitis or is this a back? Like, we have to be able to rule out the back first, or the spine first, if we can, because it's going to skew the rest of the testing if it's the spine, right? And it's going to make things very confusing. And that's where people go down this rabbit hole of like going through a plan of care and then getting stuck. Like, things start off pretty well and they plateau and they don't know where to go, or they're doing the right things for that body part and it gets worse. And like, I don't know. And they just kind of like start choosing random shit and throwing random tools at it. And like, I'm going to do dry needling and scraping and cupping and manual therapy, and we'll try different exercises. And there's not a real reason for it. It's just because it's not working. They don't know what to do. So they just try something else. Right. So then once they have that pattern down, right, and being able to classify these things as mechanical stressors in a multiple classification system where it fits in multiple buckets at once, then we can get into the testing. So if we go back to like the shoulder, a good pattern of testing is going to be, looking at active range of motion, passive range of motion, glenohumeral joint play, testing the passive capsular end feel, then getting into resisted isometrics and neutral, and then being able to do, manual muscle break tests at varying angles. And, following up with palpation and special tests, like, as needed. But we need to rule out the cervical spine in there as well. So if you're thinking, maybe this is a cervical spine, if somebody has pain with bringing their arm up or bringing their arm out to the side or whatever it is, like, we have to make sure it's not coming from the cervical spine. If they bring their arm up and then they get to a point of pain and you lift up on their head and it gets better, well, you don't need to go down the rest of the shoulder evaluation. You need to go to the cervical spine. And it's tricky too, because sometimes you'll do that traction alleviation and people will be, at whatever, 120 degrees, and then you lift up and they go an extra 10 degrees and like, it's the same. But it's not the same, because they had to go and find that pain again, right? So like, having that solid system of being able to rule things in, rule things out. And if you're a little bit uncertain about it, it's like, start off with clearing the spine before you jump into the shoulder or whatever it is, because then you're going to waste a bunch of time. If you find weakness and you find pain, like, and it's caused by the nervous system, it doesn't really matter what you do for that local tissue, right? And yeah, you're going to get a lot of information that's completely useless, because like, people can have a lot of epicondylitis that's not actually caused by the elbow, right? Like, if it was on one side and now it's on the other, that doesn't make sense. Or they get pain when they're not like gripping. That doesn't make sense. But you can palpate it and it's painful. And they can grip and it's painful. And you can stretch it and it's painful. And that's the cluster that you look for, right, with the contractile tissue. But that contractile tissue can be irritable because it's not getting the proper innervation, right? So,
yeah, I was going to say, I think something that you touched on that, especially as people begin guiding their testing, is like, even conceptualizing what they have to know about the spine, and the fact that people can be in multiple different buckets. Like, the most common things that I have seen in the clinic, or that most of, like, say when I first graduated, a lot of the clinicians in my clinic, regardless of how long they had been treating, everybody was doing just posterior pelvic tilts and chin tucks for low backs and necks. And then it's like, everybody's getting the same buckets of exercises. And the conceptualization is that those are part of the answer for some of the people, but you have to understand all of the other components for somebody to actually get better. So can you speak to, I guess, more of that?
Yeah. So like the chin tucks and the posterior pelvic tilts, like, those aren't exercises. Like, I see those get prescribed as exercises, but that is, that's a modification to avoid a mechanical stressor, right? So like, or not for the chin tucks, but for the posterior pelvic tilts. And then for the chin tucks, I actually just disagree with that whole like thought process of chin tucks, because that's to train the deep cervical flexors, the deep neck flexors, right? So like if you just nod your nose down, that's flexion. If you retract and you do a chin tuck, right, then yes, you're getting flexion. You're getting a lot of cervical flexion in a roundabout way, in a way that also causes compression and shear forces through the rest of the neck, right? So if you're treating somebody that has a cervical radiculopathy and you do a chin tuck and you're causing compression and shear forces, well, there's already hypermobility typically in that situation. So you're actually now provoking their pain while you're trying to do something. So there's much better ways to go about it, just like an isometric nose nod, right? Where you're actually just isometrically contracting those. So that's a sidebar. But the posterior pelvic tilt, and again, you need to like test and make sure that somebody even needs that, right? The posterior pelvic tilt, it's like, if somebody has an extension sensitivity, that's the utility of a posterior pelvic tilt. So they can tilt their pelvis, which directly connects to the spine, and they can move their spine away from that position of extension that they are sensitive to. If they're not sensitive to extension, then what do we need to move them away from extension for? Right? And just like tucking their pelvis is like, that's not a good exercise. What's the good utility of that is like, hey, can you, what they want to do is explore the functional range. So when somebody has pain, right, especially low back pain, there's a range that they can move through, right? The range that they can function in without pain. So we want to make sure that they can move their pelvis to control it and stay within that functional range where they don't get a pain response, right? And then the utility of the pelvic tilt is holding themselves in that functional range while we're stressing the rest of the body. Well, we're trying to create a situation that's pulling them into that position of sensitivity, and they're using that posterior pelvic tilt to resist it, right? So if you're doing like a hook lying flexion, that's going to pull them, right? They lay on their back and hook lying, and then arms are out in front of them towards the ceiling, and they go over their head. When they do that, they're going to go into extension, especially if there's a weight in their hands, right? So it's going to pull them into extension. They're using that posterior pelvic tilt to stay away from it, teaching them to do it while they're standing, because standing is an extension-based thing, right? Hey, bend your knees just ever so slightly. Unlock your knees, do a little posterior pelvic tilt. Put your foot up on something, right? So that's actually just really an educational bit of helping them understand their mechanical stressors so they can make it through their day in a way that actually allows an environment within the body that's conducive to healing. Because if they're just jamming themselves in that position that they're sensitive to all the time, it's going to stay sensitive, right? And they'll have ups and downs. And the thing with that is that like a lot of times it's time dependent, right? People can stand for a period of time or walk for a period of time, and then it starts to hurt, right? They can lay on their back and then it starts to hurt. And it can be pretty confusing for some people, but if we can teach them all throughout the day of like, hey, when you're standing, little pelvic tilt. When you're doing dishes, put your foot up underneath the cabinet, right? If you're bending forward and they tend to not move their spine at all, like, hey, you can actually do a posterior pelvic tilt and get a little bit of flexion when you're going into a hinge for whatever you need to, if it's something that's applicable to them. Yeah, so like really, it's just I think it's kind of useless except for an educational bit, and then the application of it is like during other exercises that are preventing them from going into extension, and so they can keep themselves out of pain all throughout the day. So you don't have this situation where they come in with a bunch of pain, you do some stuff to alleviate it, they leave feeling pretty good, and they just come back in all flared up again because they have no idea how to actually self-manage their pain.
Yeah. I remember entire plans of care being built around the pelvic tilt. And it's like, you start off on the table, regardless of how active somebody is. It has nothing to do with their lifestyle. Everybody's doing pelvic tilts, and then they're doing heel slides, and then they're doing leg lifts, and then maybe they're doing clams or like bent knee fallouts. The transition into performance is a complete shit show then, because you've done all of this table work, and then you get somebody standing. And this is where like the how you move matters and how you assess your patient matters comes into play, because people will do all of that in the beginning and then they just jump straight into performance, and then the patient's pain comes back. So can you speak to then transitioning into performance and breaking down movement patterns? Like we talk a lot about algorithms and being able to look at if this, then that. So can you speak to that?
Yeah, yeah, absolutely. So I think that people have to earn the right to exercise, right? Like I strongly believe that, especially if they're in a lot of pain, because we're taught that exercise is the answer. It's like, hey, come in. What exercises do I get? What stretches do I get? What do I give them? What do I have to give somebody exercises on day one, right? And like oftentimes that's actually the wrong thing to do depending on their situation. right? And depending on how irritable they are, obviously, if there's an exercise that's going to be alleviatory, it can be helpful, right? Or you're talking about a knee pain and like they need some exercise right off the bat, like cool, give it to them. But if we're talking specifically about spine pain, then there's like, especially lumbar spine, there's like a little step ladder, right, of like exploring the functional range and maintaining the functional range, and then being able to add mass body movements and ADLs on top of that. So it starts off with teaching them about their mechanical stressors. So if somebody is load, extension, and neural tension sensitive, like we need to avoid those things for a period of time. It's like having a sprained ankle. Like somebody sprains the shit out of their ankle and they want to go run, like hopefully you're not like, yeah, go run, it's gonna hurt. It's okay though, because running's not bad for your ankle, period, right? But when it's sprained and that's something that's sensitive to all of the loading and the forces, like, maybe we want to create an environment in the body that's conducive to healing. That's why they give people crutches. That's why they get, maybe an air cast. They get something to alleviate those forces to create an environment within the body that's actually conducive to healing. And then after the initial healing has taken place, they'll progressively overload it. And it's the same thing with the spine. So we have to have a full understanding of what their mechanical stressors are and what their goals are, so we can start to design an exercise program after we know that they can control their body and keep themselves out of pain in a way that looks like the things that they want to get back to, right? So like a runner's rehab should look different than a powerlifter's rehab. Yes, there will be some similarities, but especially in the later stage of the performance aspect, like things are going to be a little bit different. So what really allows us to tell like when to get more into performance is not the pain, right? And that's like a total different way that most people look at this. When people are go to PT, especially like in network PT, like what happens? They go to PT, they get treated until they don't have pain and they move fairly well, and then they're done, right? Most people have a high recurrence of low back pain and neck pain, or pain generated by those areas as well, because the lack of pain does not indicate health of the nervous system. What indicates health of the nervous system is the neurological vital signs, right? The reflexes, the myotones, the neural tension sensitivity. So we need to look for those signs to improve before we start reintroducing more of their mechanical stressors. So if somebody wants to deadlift, right, and when we look at them, they are extension sensitive, they're load sensitive, and they're neural tension sensitive, like we do not want to get them into a hinge, because as soon as they start to bend forward, right, they go from 100% of their body weight in their spine to, as soon as they bend forward, they're at 150% before they have any external loading, right? And they're sensitive to that right now. And then anytime you start to get an L-shaped position, you're pulling on the nerves, so we're getting neural tension. And then most people, when they're deadlifting or squatting, the cue is that they get a lot to get tight. So what do? They jam themselves into an anterior pelvic tilt so their spinal erectors feel tight, right? And that's not what getting tight is. They need to learn how to brace. So it's like, first thing we need to do is assess their ability, to use their glutes. In that situation, they're probably going to have some psoas guarding, right? Psoas gets a bad rap for causing low back pain. And there's this whole internet, like, can you palpate it? Can you not palpate it? Fun fact, they actually did a study and you can get in there to the viscera. They measured it with some imaging in real time. And you can actually get in there and get within like millimeters of it. So you can actually impact it manually, but that's neither here nor there. A lot of times the psoas will go into guarding and it's a symptom, not a problem, right? But if the psoas is stiff and it's turning on to guard and it's in a little spasm, if it's stiff in the front, the backside's going to have a hard time firing, which is where people drop the term gluteal amnesia, which isn't really a thing, right? It's just restricted in the front, so you're going to have a hard time activating the back. So we might start off with, if we find that, addressing that by stretching, having them stretch it, just doing some neurological downregulation, and then using that new range of motion actively, right? Or maybe we have them do a bridge to start, depending on the level of tolerance, where they do a full posterior pelvic tilt. So we make sure that they're bracing against that extension, and they squeeze their glutes, they drive their knees forward as the cue to come up, and then they squeeze their butt cheeks at the top, right? And they're getting into that hip extension. So now they're utilizing that new range. They're getting a neurological drive to the glutes. They're recognizing that range neurologically. They're a lot more likely to hold on to it. And guess what? Their glutes are going to fire a whole lot easier, right? So now we're working on that hinge pattern on a very low level, right? But if it's what they can tolerate, that's where we start. And then maybe from there, you can progress that same thing into, a march, a bridge with a march. Make sure the pelvis doesn't drop. Maybe a single leg bridge, and maybe go to hip thrust, single leg hip thrust, or march and a hip thrust, wherever you want to go, right? But you can get into like a kneeling hinge because it's as long as things are progressing well and they can tolerate that little bit of a loaded position, we're still taking care of the neural tension. And then as those neurological vital signs start to increase and their irritability is significantly decreasing, then we'll just progressively overload it and getting into a standing hinge and getting into single leg hinge, whatever it is. But maybe when we're starting that, we're starting off with a reduced range of motion, right? And it's maybe not a barbell that we're starting with. Maybe we've got a kettlebell or a dumbbell elevated on some plates. So we're reducing that range of motion and we're watching their quality. I like to think of rehab in 3 phases. And if you have a question, let me know, because I'm on a roll.
I was going to go ahead and talk about the phases. I was going to bring it back to part of the evaluation.
Yeah. So like when we're looking at treatment, there's 3 phases of treatment, right? Like, in our clinic, we call it Men Move Maximize. The first phase is all about symptom reduction, right? Like we're going to get you out of pain. And as we're working on getting them out of pain, which is a lot of education, a lot of activity modification, because the spine acts like a credit card. So, it's not the stuff in the moment that causes an issue. A lot of times people will be like, sometimes I'm doing nothing and I have a whole bunch of pain. And sometimes I do a lot and I don't have any pain. It's just like, how much have they spent throughout the day? So the first phase is getting them out of pain, right? Dealing with any contributing mobility deficits and setting some baseline strength, right? So in that case, low back, maybe they've got a really stiff thoracic spine as well, right? So anytime they're doing anything, they're going through their lumbar spine because they can't extend their thoracic spine. It's stuck in a little flexion, right? It's much easier because humans are designed for energy conservation, much easier for them to just dump their pelvis forward, go into lumbar extension. So working on setting some baseline strength, like with the bridges, that type of stuff. And then once that stuff comes down, then we're going to go into our move phase, which is where we're really going to be working on rebuilding these movement patterns. And again, it's not very loaded. Maybe it is for some things. Like you want to progress as much as we can in whatever capacity, but you might have some things that are still kind of like more phase 1 and some things that are more phase 2. And you might even have some things that you start moving to really loading the hell out of through phase 3. And you have to know where it's appropriate based on the presentation, your understanding, and what their ability to tolerate is. So phase 2 is the move phase, where we're going to work on rebuilding these movement patterns. And whatever it is for them, whether it's running, whether it's pushing, pulling, like vertically, horizontally, hinging, squatting, usually there's some combination. We're going to start doing that stuff as quickly as we can, as long as they tolerate it and everything's improving. So that is slow. It's tempo. There's pause works. There's holds. There's not a ton of load typically. And it's really making sure that they're very aware of what it feels like when they're moving, so they can learn when I fault back to extension, I can fix that. And they get an understanding of when and how it happens, and they have strategies in place to not do it, right? We want to make sure that they can move consistently before we bring in the intensity of it. So then in phase 3, like this is the most important phase. Like phase 3 is what we call, in our clinic, the maximize phase. And this is where, we are really loading people. We're bringing up the weight. We're bringing up the impact. We're bringing up the speed of movement. We're bringing the intensity super high. And people are going to need to bring a change of clothes because it's like a full-on gym workout, right? And this is the whole point of it, is to rebuild their tissue capacity, rebuild their resiliency, but most importantly, rebuild their confidence. So that way they're like, no matter what life throws at them, like they're not worried because they've already been in the clinic. They've done all of the hard shit. They've actually hit their goals, and then they can go on. Like if somebody's like, hey, that same person, their goal is to deadlift 400 pounds. And they could do it previously, right? And it's like, we need to get them deadlifting 400 pounds in the clinic. Otherwise, you don't know that they've actually been successful through rehab. If they're like, hey, I deadlift, 500 pounds, and every time I hit 400, like my back goes out. Like, okay, cool. Guess what we're doing? We're going to be deadlifting 400 for a lot of reps.
Yeah, I think that's a really good point. And we talked about like the intent of the evaluation and the clinical reasoning and how you go through all of that. And then even as you start to transition through these 3 phases of rehab, evaluating performance-based movements like squat, lunge, that kind of thing. But what's the utility of looking at functional movement patterns like a squat, or somebody who's having pain when they catch a heavy snatch? What's the utility of looking at that in an evaluation? Because there are therapists who that's one of the first things they want to look at, if it's tolerable. So is it necessary to do that in the evaluation when you already have so much to do?
Yeah, everybody's favorite answer, it depends, right? It depends on what their presentation is. Like if somebody comes in and they're like, so there's a kid that I was treating, a teenage kid, right? He had back pain during squats and football practice, right? And he wasn't practicing for football and he was just trying to squat and get strong. So the first thing we did was look at his squat, right? Because there was no other pain points, right? It didn't come on and off throughout the day. It wasn't like kind of there, kind of not. And that's what we wanted to do immediately. So I wanted to help him be able to do that day one, right? Now, that's a different situation where we went in and it's like, all right, well, show me your squat. And I looked at his air squat and I was like, oof, that's terrible, right? Like lacking mobility, valgus collapse on both knees, like just slamming down to the bottom of the squat, big old butt wink. And I'm like, oh, no wonder it hurts when you're squatting if this is what it looks like with your, just your own body weight. So, then did a quick screen of joint mobility and found he had some restrictions in his hips and his ankles and decided the ankles were probably the most important thing. So I elevated his heels, had him squat again, like 70% better. Right? Cool. And then I asked him, hey, how do you brace your spine? And he was like, what does that mean? And I looked at his dad because his dad was there. And I was like, well, and his dad's the one that taught him how to lift. Like, how did you teach him to brace his spine? And dad's like, deer in the headlights. Look, I'm like, all right, so let's go through this bracing sequence, right? Let's learn this. And now let's do some tempo squats. Let's focus on controlling the way down, creating the rooting, right? That rotational stability at the proximal ball and socket joint, and bracing the spine, 4 seconds on the way up. Let's do that for, 10 reps, 10 seconds down, explode up, 10 seconds down, explode up, right? And he was able to do that totally fine. So then we went to a barbell. Right. And when this kid came in, his dad would let him squat up to 275. So I don't know why he had him stop there, but that's where he would stop. But the kid would get pain at 135. And just changing those things throughout that day, I was able to get him to squat up to 225 for reps. And we just stopped there because it looked like he was struggling, right, to actually do it well. So we were able to accomplish that goal day one. And then from there, I was like, all right, so we've got this down. But we've got to look at the underlying stuff and see, what else is going on. And then we went back over to the table and then we looked at his neurological vital signs, right? Because now we have a metric by which to measure the health. And lo and behold, he had some neural tension sensitivity, some load sensitivity, right? He didn't have a positional sensitivity. And then we can get in and we can educate him on taking care of the stuff, the other 24 hours of the day. Because he feels his pain when he's squatting, but the rest of the day is also keeping him aggravated and keeping the nervous system irritated. He's a student. He's a teenager. He goes to school. He sits all day in a loaded position, and then he squats in the evening. I go, okay, well, now we know that you've been irritating it all day long. Also, stretches his hamstrings. Like, all right, and his hamstrings aren't tight. Like, maybe we stop doing that for now, right? So we gave him education around the rest of the day. So it's like we started there, but then we looped it right back around because you need that information. Otherwise, you have no metrics. Some people will come in and be like, oh, well, I'm squatting. He's fixed now. He's good, except for his nervous system still irritated. And at any point in time, that thing could just flare up.
Yeah, I think that's a good point, especially with because something that I've heard you say multiple times is like, you can't rush healing timelines. And for people who are better in 1 visit, 2 visits, what can clinicians do?
Yeah, well, that's a catch-22. Like, who's better in 1 or 2 visits, right? Like, you can't rush tissue healing timeframes. They're not symptomatic in 1 or 2 visits, right? And if you define better as not having symptoms, then you're setting yourself up, you're setting your patients up to have recurrent pain, right? Like, we can modify the hell out of symptoms. Like, you can needle something and get rid of pain entirely in 1 visit. Doesn't mean it's fixed. Doesn't mean it's not going to come back, right? So, like, we need to be looking at the contributing factors. Like, okay, cool, you've got a rotator cuff pain. Awesome. Like, we can get you doing external rotation by your side in neutral, but like, what's the actual stability in different ranges of motion? How's the periscapular stability, right? How's the thoracic spine stability? How's the rhomboids, the mid traps? How's the serratus anterior? How's the low traps? Like, we need to look at the whole quarter as a picture and get everything operating well. And then we also have to look at the movement patterns, right? So if they have pain, like, potentially their movement patterns, depending on the situation, right, played into why they have pain. So we can modify the symptoms, and if we don't modify the thing that irritated in the first place, if we don't fix that, like it's gonna probably come back, right? That makes sense. So we have to look at, the whole regional interdependence thing, make sure that the whole quarter essentially is working correctly. We'll say, put that in quotations marks, right? And then modify the movement patterns that are playing into it.
Yeah. So let's say a clinician is like, okay, so I know I need to get better. I don't know where to start. My clinical reasoning isn't the best. I feel like I'm decent on performance. What's one place they can start?
In the Performance Rehab Authority Certification. Actually, for real though, we have like a baller ass school group that you guys should join, because there's a ton of valuable information in there. But shameless plug aside, the biggest thing would be organizing their thought process in the evaluation, right? Like familiarizing yourself really with the pain and like asking yourself when people come in, does it even make sense for the local body part, right? Like if somebody comes in and they have plantar fasciitis, right? Or plantar fascia pain, there's so many things that could play into that, right? Like it could be L5, could be S1, could be S2. Like look up Google image, just L5 dermatome bottom of the foot, and you'll see a bunch of different images that show like there's a bunch of different innervations down there, depending on which one you look at, where it is. But then you also have like the abductor hallucis, the flexor hallucis, like there's the posterior tibialis. There's so many different things that go on in the bottom of the foot, and being aware of the pain patterns that might fit a local tissue. Right? If it is a plantar fasciitis, it's like, hey, they wake up and they don't have pain. And they put their foot down, they have pain, because plantar fasciitis or plantar fascia pain is a tension problem, right? Like the arch is there and then it stretches out and it creates tension and then it's painful. And then the pain behavior is that they take a few steps, maybe 10, 15 steps, it feels better, right? And then it doesn't get worse. It's not like it feels okay when I'm walking and then like I walk for a while and then it gets worse. Then I start to feel it after I've been walking for a mile. That doesn't make sense because that doesn't fit the local tissue pain pattern. And that should make you go, right? Don't just jump to conclusions based on what the patients are telling you for where they feel their pain. Like you have to look at, is there a mechanism of injury? Does it make sense? And if it doesn't, what else would make sense? Even if they don't have back pain, even if they don't have leg pain, even if they have no history of those things, it would make more sense that somebody has maybe an extension sensitivity and they're walking around for a long period of time in extension, and then it starts to get irritated and then they get that pain down their foot, versus I've done nothing differently. I've not changed my activities. I've not done anything, and it doesn't follow the pain pattern of a plantar fascia pain. You don't go down the plantar fascia rabbit hole just because that's where the pain is located. That is like the number one thing. We have to remember that pain is created in the brain, right? It's not even felt in the body. It's like a pretty complex process. But to simplify it, there's the nociceptors, right? Shoot up to the brain. It interacts with billions of neurons, and then your brain says, oh, maybe I should send pain out to this area. And there's a lot of overlap with, if you guys remember your neuro classes, with all those different pathways, right? That's why people can have like face pain, and they can have ear pain and a full sensation of fullness in the ear, and like TMJ pain and tinnitus from a joint hypomobility, because it goes up, interacts, and like it's all pretty close, and some of those pathways overlap, and then it just comes back down as pain in the wrong area. Like it happens all the time.
Yeah, I think that's fantastic. For anybody who is not already part of our school group, we have a ton of clinical and business resources in our free school community, the Performance Rehab Authority. So be sure to check that out. You can get the links on either of our Instagrams, doc.raj or Dr. Caitlin Vella. My name is Dr. Caitlin Vella. I'm the co-founder of the Performance Rehab Authority. My partner, Doc Raj, that we just interviewed, has done a residency, 2 fellowships, and literally mentors clinicians internationally. And so we're super proud to bring you this episode and to continue answering all of your questions.
Catch you guys on the flip side.